afternoon, Mr. Chairman, ladies and gentlemen. I would like to thank the organizers for the kind invitation. Head mass used to be described as a focal enlargement of the pancreatic head on ultrasound, or CT, which is 3.5 or so centimeters anterior-posterior extent over the vertebra. However, US redefined it to mean any mass with a distinct image characteristics or pressure effect. In fact, this can also be an operative finding. So in our approach to the head mass today, we have two major problems: how to diagnose reliably an inflammatory mass versus cancerous mass, and of course, how to treat it. And we're not talking about differentiation of mass lesion in the pancreas as whether it's inflammatory or neoplastic, but we are actually looking at a differentiation of a mass lesion in chronic pancreatitis, whether it's benign inflammatory or a superimposed neoplasm. And I've said two conditions, but there are actually three conditions there: mass-forming pancreatitis, autoimmune pancreatitis, and groove pancreatitis. And we're not going to talk about autoimmune pancreatitis today, so the other two we're going to talk about. I'm going to try and answer 5 questions, which I have posed to myself. First of all, what is the risk for cancer? You need to understand that to know how profound the problem is. There have been Western as well as Indian series which have suggested that the cancer risk among these patients may range from 8.3% to 16%. In the group in Stanley Medical College, which is of course a surgically resected group, a third of the surgically resected patients had cancer, which is quite understandable. The second question is, how good are we in diagnosing cancer reliably? And this is a big problem. And there are 5 components to our diagnostic process: clinical, imaging, biopsy, molecular techniques, and artificial intelligence. In clinical, if you have anorexia, which is of course a widely prevalent symptom, worsening of glycemic status or a new diabetes, absence of weight loss, of course, is a very good negative predictive factor, and an obstructive jaundice with a bilirubin of more than 5 milligrams, this is kind of very highly suggestive of cancer. Various imaging modalities are available. Biopsies can be done percutaneously or more likely EUS or even intraoperative frozen. Molecular-wise, we could do a KRAS2 mutation in circulating DNA, which is, if it's absent, it rules out cancer, but it can still be cancer. Plasma mRNA is a relatively new kid in the block, but it has specificity, but not that much sensitivity. And there are others as well which are developing. Now with AI, we are trying to use computer-aided diagnosis and try to improve on our diagnostic skills. If there is a change of intermittent type B pain to a continuous type A pain, then it's an important sign. Array CA19-9 in Manmohan Singh Bedi published that if you had a value of over 300 in a patient with chronic pancreatitis, it was nearly always cancer. Of course, this need not be true in all cases. When we do imaging, there are a lot of findings. And the ones at the top, duct penetrating sign is the one most appreciated. The others are not really that beneficial in differentiating the two. The duct penetrating sign really means that the duct appears to go through the mass, and that suggests that it's not cancer. One of the observations that we made and we published is that unlike de novo adenocarcinoma, which hypo-enhances compared to the surrounding parenchyma, cancer in chronic pancreatitis shows enhancement compared to the rest of the atrophic parenchyma. And if you look carefully, you can see that the atrophic component lights up, the cancerous component lights up, and you have several examples of this in these cases. If you have serial CTs, it's very valuable. You don't see the enhancement here, and you have seen an enhanced mass here, which was later on proven to be cancer. And this is a very graphic example of a small enhancing mass within a dilated atrophic gland, which turned out to be adenocarcinoma, and a close-up of the same. It used to be said that FDG PET has got a great overlap in terms of chronic pancreatitis and cancer, and therefore it's not useful. But now, dual time point PET-CT has made a difference that if you, do study the standardized uptake value in the early and delayed phase, and if the delayed phase was higher, uptake was higher, that is likely to be malignant. Whereas if the retention index cutoff is 3.6, then it's more likely to be malignant. If it's negative, it's benign. So if it retains, then it's cancer. So FDG PET perhaps is useful even in the absence of metastasis. If there's metastasis, of course, it's a given. Biopsy, the problem with chronic pancreatitis is that there is so much fibrosis in the gland that EUS, which is so sensitive in diagnosing cancer in other situations, comes down to 75 and 80%, and even that may be a very ambitious figure. It is not so effective in patients with chronic pancreatitis. In spite of use of rapid on-site evaluation, in spite of the use of EUS elastography and contrast-enhanced endoscopic ultrasound, we still haven't reached a great deal of diagnostic accuracy in cancers in chronic pancreatitis. I'd like to emphasize 2 points: that if we are going to stent a patient, for heaven's sake, we must do a cross-sectional examination before, because one stent artifacts will destroy everything. Even EUS will not see the change in diameter of the duct, which is probably where they will train their EUS eyes. And so it is always better to do these tests before you actually do a therapeutic stenting. Also, the other problem is that the biggest conundrum is that vascular involvement, adjacent organ involvement, and unresectability could well be signs of cancer, but they need not be in chronic pancreatitis. They could actually indicate cancer or chronic pancreatitis. Frozen section is being used more and more. Repeat sections may be required. A transduodenal TrueCut kind of a biopsy or bioptic gun is advisable. And generally, they still follow the age-old Highland criteria, and I'm always worried whether they're giving me the right diagnosis. I spoke about the molecular aspects, and in the era of computer-aided diagnosis, I just want to explain to some of my younger colleagues that radiomics, what it does is it extracts a large number of features from the medical images by just taking bits of it out and then constructing a mosaic and then comparing it with using data characterization algorithms. And this is a part of a major omics process where you look at the genome, you look at the transcriptome, you look at the proteome and the metabolome, which is the output. In fact, some of the molecular tests that we talked about are the metabolomes because they are the outputs, and they all affect phenotype and function. So this may be the new era of omics that we are talking about. Even the prediction models that we use in our day-to-day practice, and if you have a prediction model which we simply enter in the Excel chart, and as you enter all the values, you will get the Z value, and you have previously identified what the cutoff is based on sensitivity and specificity. You can use it to predict whether your patient is having cancer or not, and 3 centers have different algorithms for the same. The machine learning actually does this using several modules, and we are still far from accurate. Despite all this, in our experience, 27.5% of mass lesions in chronic pancreatitis, which were presumed or proven to have malignancy, not proven malignancy, presumed to have malignancy, were ultimately benign. And that shows that we have obviously not got it right. We tend to veer on the side of playing safe with cancer resection when it actually does not mean cancer. Groove pancreatitis is a paraduodenal pancreatitis, where the inflammation is largely confined to the paraduodenal area. It may affect the bile duct, the duodenum, and the portion of the head, which is in the groove, the pancreaticoduodenal groove. And it may be a pure groove pancreatitis, or it may extend beyond the pancreatic head, in which case it's a segmental groove pancreatitis. And it's got various components. It may be solid or cystic. It may produce biliary obstruction or not. It may produce duodenal obstruction or not. In many cases, there will be a main pancreatic duct dilatation, and they may even be calculi. And in many patients with chronic pancreatitis, there is a superimposed sort of paraduodenal component. But in general, it means there is acute inflammation. In general, it means that there is ethanol misuse, and the CRP is usually high. So finally, what do we do with these head masses? So why don't we resect all the masses and be done with it? This is a paper from Jacob Isbicki's unit in Hamburg, which talked about the 15-year follow-up after Whipple procedure. My own take is that patients may already have exocrine and endocrine insufficiency, and an inappropriate resection would condemn patients to a lifetime of pancreatic insufficiency. In cancer, anyway, your survival would be poor. And in fact, it showed that the general survival of patients who had Frey procedure was substantially superior to those who had Whipple resection. So my algorithm would be to study the variables. If it's positive, then do a Whipple resection. If it's presumptive, again, you may have to play your cards and do the Whipple procedure. If it's negative, of course, you would do a Frey. And what for the groove pancreatitis? I would treat them conservatively with nasojejunal feeding, do a US FNA if required to rule out cancer, do endoscopic biliary stenting in selected cases. And the definitive management would depend on whether there's a suspicion of cancer, whether there was presence of MPD and biliary dilatation, which means a double duct obstruction, and is it superimposed on a general chronic calcifying pancreatitis, in which case it would obviously slot into different systems. Surgery, if required, would be interval, head resection where malignancy is proven or suspected. And in many cases with groove pancreatitis, we are happy to say that a head coring or a main pancreatic duct drainage with or without duodenal or biliary bypass is quite sufficient. Thank you very much for your attention.